All right, we're going to talk about cardiac amyloidosis. And look, here's why this is so important. This isn't some rare textbook-only condition. It's a critical and way too often missed cause of heart failure. And I guarantee you, you will see this in your career. Spotting it early can totally change a patient's life, so let's break down exactly how to do that.
Okay, let's kick things off with a classic clinical puzzle. You've got a patient, probably a little older, who comes in with heart failure, but their echo shows a preserved ejection fraction. They also happen to mention, oh yeah, I've had surgery on both wrists for carpal tunnel, and I've got a bad back, spinal stenosis. At first glance, these just sound like separate, unlucky problems of getting older, right? But what if they're all pieces of the same puzzle? Just keep that question in the back of your mind.
So, to answer that puzzle, we've got to go back to square one. We need to understand the fundamental problem here. What even is amyloid?
So here's the deal. In a healthy body, proteins are supposed to be soluble, just floating around, doing their jobs. But in amyloidosis, something goes wrong. These proteins misfold, and when they do, they get all rigid and sticky. They start clumping together outside the cells, forming these incredibly tough, insoluble fibers, or fibrils. You can literally think of it as microscopic concrete being poured into organs where it doesn't belong, gumming up the works and causing all sorts of damage. Let's walk through how this actually happens. So it all starts with normal proteins just cruising through the bloodstream. But then, for a variety of reasons, they start to misfold into this very specific, very rigid structure called a beta-pleated sheet. Once they're in that shape, they're no longer soluble, they're sticky. They just start stacking up on each other, forming these tough fibrils. It's like a soluble protein is like wet cement, it's flexible. But once it misfolds, that cement sets. And in cardiac amyloidosis, that concrete is getting laid down right in the heart muscle, making it stiff, thick, and unable to relax and fill properly. Now, there are a bunch of different proteins that can form amyloid, but in cardiology, we are laser focused on two main culprits. And telling them apart is one of the most important things you can do because their cause, their treatment, and their prognosis are wildly different. And this chart really puts things into perspective. You can see AL amyloidosis is the most common systemic type we find. It's related to a plasma cell disorder. But look right behind it, ATTR. It's a huge player, and honestly, we're just getting so much better at finding it, which means you're going to be seeing it a lot more. And this right here, this slide is absolutely crucial. For AL amyloidosis, you can think of it like a cancer-related process. Rogue plasma cells are just churning out these bad, misfolded light chains, and it is incredibly aggressive. If you don't treat it, the median survival is less than a year. Now compare that to ATTR. That comes from a normal protein made by the liver. It can happen just as a process of aging, we call that wild type, or from a genetic mutation. And the prognosis, look at that, a median survival of 75 months for the wild type. That massive difference is exactly why we have to get this diagnosis right. So the million-dollar question is, when should you even be thinking about this diagnosis? Let's get really practical and go through a checklist of red flags that should make your amyloid alarm bells start ringing. Okay, on the heart side of things, the classic picture is heart failure with a preserved ejection fraction, or HFpEF. The echo shows really thick heart walls, but it's not from high blood pressure. You might also see arrhythmias or heart block because that amyloid concrete is getting into the heart's electrical wiring and messing it up. And very often, the cardiac biomarkers, troponin and NT-proBNP, are just sky high, way out of proportion to how sick the patient might seem. Now, if you remember one thing from this talk, make it this. This is such a high-yield clinical pearl. You get an echo, and it shows a massively thickened, beefy left ventricle. Logically, you'd think the EKG would show really high voltage, right? More muscle, more electricity. But instead, you see low voltage. That mismatch, a big heart on the image, but small electrical signals on the EKG, that should scream infiltrative disease at you. It means something is replacing that healthy conductive muscle, and that something is often amyloid. But you know, the clues are very often outside the heart. And this brings us right back to our patient from the beginning. Bilateral carpal tunnel syndrome and lumbar spinal stenosis are huge red flags for ATTR amyloid. And they can show up years, even a decade before the heart failure. Other things like neuropathy, weird gut issues, that classic raccoon eye bruising around the eyes, or an enlarged tongue are also huge clues. It's putting the cardiac and these non-cardiac clues together that really clinches your suspicion. Okay, so your suspicion is high. You think you might be dealing with amyloidosis. So how do you prove it? How do you nail the diagnosis? Well, the good news is the diagnostic pathway has gotten so much clearer, and in a lot of cases, it's totally not invasive. So here's the modern game plan. It all starts with you, with your clinical suspicion from all those red flags. Step 2 is absolutely non-negotiable. You have to screen for monoclonal protein with blood and urine tests. You've got to rule out the bad actor, AL amyloidosis. At the same time, advanced imaging like a cardiac MRI can give you more clues. And then, these first few steps point you toward the final, definitive test to confirm it and, most importantly, to type it. And this right here, this is the game changer. It's a nuclear medicine scan called a technetium pyrophosphate scan, or PYP scan. Now, it's technically a bone scan, but for reasons that are really cool, the tracer loves to bind to ATTR amyloid deposits in the heart. So if the heart lights up like a Christmas tree on this scan, and your monoclonal protein screen is negative, boom, you can diagnose ATTR cardiac amyloidosis with incredible certainty without ever needing a risky heart biopsy. It's an unbelievably powerful tool. But I have to stop and really hammer this point home. This is probably the single biggest pitfall in diagnosing amyloid. A lot of older adults have a little benign monoclonal protein floating around. It's a condition called MGUS. Now, imagine an elderly patient has a positive PYP scan that's screaming ATTR, but they also happen to have this incidental MGUS. You could easily misdiagnose them with AL amyloidosis, and that is a catastrophic error because the treatments are completely different. You must always prove what type of amyloid is in the tissue one way or another. So let's end with this thought because it's a really powerful one. For decades, a diagnosis of cardiac amyloidosis was basically a death sentence. There was nothing we could do. But now, we have these amazing, targeted therapies for both AL and ATTR that can stop the disease in its tracks and actually improve survival. This totally changes it from some interesting diagnosis to a treatable condition. So the next time you see that patient with so-called idiopathic heart failure, especially HFpEF, ask yourself, could this be amyloid? Because you finding it, you making that connection, that could literally change their life.